him putting me on this gathering. And when he asked me to speak about persistent and chronic diarrhea, it was very confusing because telling in 40 minutes what is written in a textbook is very problematic. And I remembered a joke when a group of friends gathered together for food, and they asked one of them to tell them the story of Moses alayhi salam, and he spent all the night telling without any food. And in the next time, he asked them to tell the story of Joseph alayhi salam, and they said nothing. A child was lost and then was found. Thank you. So I'm trying to put myself between the story of Moses and the story of Joseph. Uh, so I would be happy if you can tolerate this. We are going to have this definition because behind definitions, many problems are hidden. As you know, diarrhea, you should have the criteria of frequency, consistency, and volume as well. And to tell it is an acute one, it should be of acute onset. This is very important. The onset should be acute and should vanish and disappear within 2 weeks. And the episode of diarrhea, if didn't disappear within of this acute diarrhea within 2 weeks, this is persistent diarrhea. On the other hand, chronic diarrhea means something that started insidiously. So the mother cannot define the exact time at which diarrhea started. And there is a very wide range from 2 weeks, 3 weeks, 4 weeks, 2 months, but the most accepted is 1 month duration to define chronic diarrhea. And in spite of all these definitions, I tested when patients came for chronic diarrhea diagnosis. I found the mean duration was 3 months. So even definitions, when they are there, patients are not very sticky to the definitions to come to you. Let us start with this persistent diarrhea that was previously called post-enteritis disorder, with its etiology similar to the acute one, whether viral, bacterial, parasitic, and all viral causes of acute gastroenteritis are the same causes of persistent diarrhea, whether viral or bacterial causes, a list, or parasitic conditions or infestations. And the question will be, then why these persons failed to respond within 2 weeks and the others succeeded? And here, the factors favoring persistence. Number one, antibiotic use. If you use an antibiotic, you increase the chance of persistence. If your nutrition is not good, nutrition of the patient is not good, defective nutrition will enhance persistence. If there is underlying food allergy, persistence will occur. If gut peptides are released non-balanced, it can increase the persistence. Excessive cytokines, toxic bile salts, and small bowel bacterial overgrowth are among many studied risk factors for persistence. And here in this very complex diagram, I can go through the process that started with the infection, for which an antibiotic was used wrongly, with cytokines that are released, and these antibiotics can disturb the flora with dysbiosis, with decreased immunity, with more bacteria in the small intestine, small bowel bacterial overgrowth or small intestinal bacterial overgrowth that lead to abnormal bile salts. All these, in addition to the malnutrition, defective gut peptides, and allergic possibility of macromolecules, you are going to lead to persistent villus damage. And here the process will start with this persistent villus damage, leading to persistence of the diarrhea even after disappearance of the causative agent. And this persistent diarrhea can lead to malabsorption. And again, this malabsorption can lead to malnutrition, and a vicious circle is settled And if you are going to stop this vicious circle, you need to stop at different points of this diagram. So the ultimate clinical presentation of persistent diarrhea will be persistent diarrhea malnutrition syndrome. And the diagnosis is clinically done. It does not need many investigations. And the stool analysis may show the same causes or may not show anything. Electrolytes and acid base should be assessed because this is the same like an acute diarrhea. Assess nutritional status as well. Treatment is very problematic, and treatment of the cause will not resolve the persistent diarrhea. Many publications about probiotic therapy with different strains in cases with persistent diarrhea, nutritional manipulation, and the best of which is breast milk. Modified formulae may help in this issue, whether by decreasing the lactose or by making it hypoallergenic, partially hydrolyzed, or even using an elementary diet, or using a plant-derived food preparations. All these manipulations may succeed, and actually a doctor should be like a tailor who is aware to which case he can use which type. Method of food administration may help, and sometimes in severe conditions with persistent diarrhea, we may resort to gavage feeding, whether in a small boluses or in a continuous drip. And my previous research showed that continued drip for at least a few days through a gavage is very helpful in these conditions. Let us move to chronic diarrhea. And actually, it's a great problem. And we can classify according to the onset of the disease, whether it started in the neonatal period or post-neonatal. And in the neonatal time, we have different diseases that can start in the neonatal period. But first of all, before thinking in neonatal etiology of chronic diarrhea, you should assess first that it is diarrhea. And in many cases coming to me with this presentation of chronic diarrhea, it's clear that it is a gastrocolic reflex that is not a chronic state of diarrhea. However, if it is diarrhea and according to purging rate, you found that there are great loss of stool and you have different problems in addition to the diarrheal definition, you have this microvillus inclusion disease. And this is either congenital that starts in the neonatal period. However, common presentation may start after 1 to 2 months of life. And this is called late onset, with prognosis being drastic and bad in congenital type that starts in the neonatal period and may ultimately ends into dehydration and death. Males are somewhat more affected, and among the cases I see, the males are still having a little bit predominance, 60 to 40. More than half of the infants are preterm. So if you have this preterm person, put in mind the possibility of microvillus inclusion disease. Before the age of 9 months, 3/4 will die. And diagnosis need histology. And if you don't have the electron microscopy, ask your histopathologist to test by periodic SHF staining. And if you didn't ask for this stain, you may miss the diagnosis. One of the very important points when you receive the staining of the biopsies, you will find abnormal staining at the upper part of the crypt cells or lower part of the crypt cells. If you found it in the upper part, this is a congenital microvillus inclusion disease. And if staining in the lower part of the cells of the crypts, this is a late onset disease that may survive with you. Treatment is easy peasy lemon squeezy. Death is expected, and we use parenteral nutrition and sometimes enteral nutrition may be used in some of the cases, and in late onset, they start to tolerate some of the enteral feeds in addition to partial parenteral nutrition. Before the age of 3 years, you don't expect to have, even in the late onset type, a survivor, but because of the central line infection and complications like liver failure, they are going to die. Some of the cases underwent intestinal transplantation and some others with intestinal and liver transplant as an option of therapy. In my series, I have one case that succeeded and the transplantation was in USA. The second important disease that is important for our Middle East context is tufting enteropathy. And I think it's related to consanguinity because I see many cases and I know my friends in Gulf see many cases of tufting enteropathy. And it is secretory congenital diarrhea. And usually diarrhea is very severe, starting in the first few days of life, and usually they die from dehydration. These infants require immediate parenteral nutrition, and they need it for life. And the diarrhea continues to lesser degree even when nothing is given enterally because this is secretory diarrhea in addition to the osmotic fraction. Sometimes we meet patients with milder presentation. And I have a twin with tufting enteropathy living till the age of 10 years up till now, and without a complete need for total parenteral nutrition. Then we are coming to the post-neonatal diarrhea, and I will discuss some other diseases that can persist for post-neonatal and at the same time they can occur in the neonatal. Then follow. If you have this diarrhea, I can classify it into bulky fatty diarrhea or what's called steatorrhea, or we can classify it into watery diarrhea, or we can classify it into inflammatory or mucoid bloody diarrhea. And in my practice, I found this classification is very practical and helpful. In the bulky fatty diarrhea, thinking pancreatic disorders, chronic pancreatitis, cystic fibrosis, Schwachman-Diamond disorder or disease, hyperlipidemia, and from the congenital point of view and the genetic point of view, cystic fibrosis stands as the most important. In pancreatic disorders, you may have severe malnutrition, small bowel bacterial overgrowth, or chronic pancreatitis. And actually, cystic fibrosis is the most common type of this. Another syndrome is June syndrome. Another one is Johansen-Pleasure syndrome. If you don't have the Elleni-Zai abnormality or deafness in or cleft palate, this is Donnellan syndrome, not Johansen-Pleasure. In my practice, I met just one of each of these disorders, but Pearson bone marrow syndrome, I have seen 3 cases. Isolated pancreatic enzyme deficiencies, enterokinase deficiencies, some familial pancreatitis with mutations in the trypsinogen gene may be the cause. So pancreatic disorders may be acquired or may be genetically determined, and it's not only cystic fibrosis. Most of our colleagues, when they find a pancreatic pathology, they think first in genetic cystic fibrosis. This is okay, but please exclude as well the acquired forms of chronic pancreatitis, of malnutrition, and small bowel bacterial overgrowth severe type. Hepatic disorders may be a cause of steatorrhea as well, whether they are congenital infections or chronic acquired chronic infection, biliary disease, metabolic or vascular, or even a congenital disease that starts even in the neonatal period. Sometimes it starts later after the neonatal period, which is abnormalities of bile acids. and actually a primary acid bile acid malabsorption is a rare disease, and it is due to reduced secretion of hormone fibroblast growth factor 19. This is a suggested pathophysiologic mechanism of this primary bile acid malabsorption. And when this factor is decreased, the excess bile acids will lead to diarrhea, and any disease that affects the terminal ileum will lead to accumulation of bile acids. As you know, that the site of absorption of bile acids is the terminal ileum. If terminal ileum is resected for any cause, you can have this pathology as an acquired situation, not as a primary acid disorders. Symptoms develop in infancy with diarrhea and failure to thrive. Patients may also have low levels of low density lipoproteins, and the diarrhea is exacerbated when fat is taken and it persists during fasting. To diagnose this primary bile acid malabsorption syndrome, we should find out the bile acid in the stool, but this is for research, and another CHCAT test that is using a capsule with a gamma emitter, selenium 75 homocholic acid, may be of help in the diagnosis. It's now available in some of the research laboratories. Intestinal causes of bulky stool may be a parasitic infestation, and on top, Giardia lamblia will come. Sometimes we have this obstructive effect of ascaris as well that can lead to a problem of bile itself. Small bowel bacterial overgrowth, short bowel syndrome, intestinal lymphangiectasia, Weber's disease. We may have early onset steatorrhea, and here you can look at the intestinal lymphangiectasia, which is a primary disease or secondary disorder, and leak from the lymph because of its dilatation of the lacteals will lead to protein losing enteropathy, will lead to decreased number of lymphocytes, what's called lymphopenia, decreased immunoglobulins in the blood, hypogammaglobulinemia, panhypogammaglobulinemia, or may lead to malabsorption features. And in my practice, I'm following 32 cases that have been diagnosed something else all through the journey to diagnose the edema. And most of them are diagnosed before the age of 3 years. Etiology of the primary type is still unknown. Familial tendency may be seen, and the main symptom is predominantly bilateral lower limb edema. So when you see this person coming to you with lower limb edema, first of all, you'll think of hypoproteinemia. It's okay. And you find a low protein profile. Then you are thinking renal disease, especially in some of these cases, diarrhea is not that severe or not that evident, because in steatorrhea, mothers will not tell that there is profuse diarrhea. And then you are going to think in GI disease, and the approach will be mentioned later. Edema may be moderate to severe, and sometimes with pericardial and chylous ascites, pericardial effusion. In some patients, lymphedema due to abnormal lymphatics is there, and the dilemma is here. When you press, you are going to see hard edema, not soft edema, and you are going to see this is a Milroy edema, and you are going to neglect the gut pathology for a while till you have more and more edema with anasarca, ascites, pleural effusion, pericardial effusion, and then you are going to sink in intestinal lymphangiectasia. Get antitrypsin, alpha-antitrypsin. If it is high, this is protein-losing enteropathy. Then take your biopsies and see the dilated lacteals, and the endoscopy may show these localized parts or may show these whitish patches, and the endoscopist may be, especially if they are not familiar with these disorders, may say this is candidiasis of the duodenum, and no, this is not. This is a case of intestinal lymphangiectasia. You can ask the help for even video capsule endoscopy, and you can find it. Some other diseases will give you acquired or secondary intestinal lymphangiectasia, and will give the same picture of intestinal lymphangiectasia. Among these are constrictive pericarditis, intestinal lymphoma, celiac disease, severe small intestinal bacterial overgrowth, Crohn's disease, intestinal tuberculosis, sarcoidosis, and others. Another point of importance that some of these persons will have a B-cell lymphoma later in life, leading to catastrophic deterioration of the condition. Low-fat diet with medium-chain triglycerides, mostly for life. So, other treatment like antiplasmin, octreotide, corticosteroids have been tried as add-on therapy to the dietetic management, and actually results are inconsistent. Surgical consideration in localized forms is helpful, and in two examples in our practice, we have seen a lymphangioma of the mesentery that when resected, the intestinal lymphangiectasis was cured, and get sure that there is no associated lymphangioma of the omentum or of the mesentery. Enterocyte biochemical defects may include familial beta-lipoproteinemia, beta-lipoproteinemia, or chylomicroretention disease. And because these diseases are not common, I will bypass them, and you can take the presentation from Dr. Islam. And the histopathology endoscopy may not be able to define them, but sometimes pearly appearance like pears, it's like pears of the mucosa, shiny appearance may be the only finding that directs you to chylomicroretention disease. And this is electron microscopy showing the chylomicron accumulation in an electron microscopy in one of our patients. Beta-lipoproteinemia may be diagnosed even with the blood film to reach the diagnosis if a hematologist is oriented with acanthocytosis. Early diagnosis with vitamin E therapy will prevent the neurologic complications of these conditions, or otherwise they are going to die early. If you look at this table, you can expect a beta-lipoproteinemia or hypo-beta-lipoproteinemia homozygous type when you find the manifestation severe in comparison to chylomicroretention disease. Then we are moving to watery diarrhea, and on top parasitic infestations will come, chronic infections, especially CMV colitis, and I will draw the attention of my friends of pediatricians that cytomegalovirus colitis is increasing nowadays. I'm not sure why, but we frequently see them, and sometimes they are mixed with or interchanged with an inflammatory bowel disease. They can occur on top of inflammatory bowel disease, and they can occur on of deficiencies or of diarrhea. Celiac disease, and Dr. Tawfiq make a very excellent lecture about celiac disease. Lactose intolerance can lead to watery diarrhea. Sugar malabsorption, whether a primary genetic disorder like glucose galactose malabsorption syndromes, or something like sugar intolerance like pentose intolerance in some cases of toddlers diarrhea. Acrodermatitis enteropathica, and this is a picture of dermatitis enteropathica. You can find inflammation of the mouth, of the perianal area, and the excoriation, in addition to the chronic diarrhea. Inflammatory bowel disease, especially Crohn's, can come with watery diarrhea. Ulcerative colitis will come with bloody diarrhea more, and this is not a definite differentiation. Functional diarrhea, that was used to call toddler's diarrhea as one of the functional GI disorders presents between the age of 6 months and 60 months, between 6 months and 5 years. IBS may have a special pattern with diarrhea, especially the diarrheal type. Endocrinal disorders like hyperthyroidism can present with diarrhea. Pancreatic cholera as a part of any amine precursor uptake and decarboxylation tumors. And I met myself 5 cases of neuroblastoma presenting with chronic diarrhea and nothing else. And we proceeded to discover it as a neuroblastoma. Drugs and radiation, take a drug history, you will find some of the medicines, especially antibiotic abuse, will lead to diarrhea. Mineral diarrhea, and one example is the zinc in acrodermatitis enteropathica, or chloride diarrhea and congenital sodium diarrhea. I know that chloride diarrhea is more in the Gulf region, and my friends usually present many cases. We don't see that frequency of chloride diarrhea. And you can differentiate by this table between chloride diarrhea and congenital sodium diarrhea between assessment, one test, stool pH. If it is acidic, you are speaking about chloride diarrhea. If it is alkaline, usually you are speaking about congenital sodium diarrhea, but you can have a pH, serum chloride, serum sodium, serum potassium, and you can differentiate by all these parameters that does not need the help of an endoscopist or gastroenterologist. Bloody mucoid diarrhea or inflammatory diarrhea can be due to infection in amoebic dysentery, inflammatory bowel disease, especially the ulcerative colitis or Crohn's colitis, food protein-induced allergic proctosigmoiditis that was called before allergic colopathy, happening with food allergy, especially cow's milk allergy. Eosinophilic colitis may be a cause. In my practice, I have seen bloody mucoid diarrhea 10 times, and the pathology proved to be very large infected polyp. And endoscopy here will be the cornerstone in the diagnosis. In graft versus host disease, it comes mostly with this, it can come with the watery diarrhea, but it usually comes in a form of bloody diarrhea. So if you have this chronic diarrhea and the failure to thrive, how to proceed? Get stool analysis and the cultures. Is it infectious diarrhea? Please start your specific treatment. If it is non-infectious diarrhea, then you are asked to see whether it is watery diarrhea or bulky stool. If it is watery diarrhea, test for carbohydrate fermentation. I will mention how. And if carbohydrate fermentation is negative, proceed to colonoscopy. And if colonoscopy was free, you can find, you can search for vitamins or mineral disorders causing diarrhea. Or if it is abnormal, you can reach the diagnosis. In sugar malabsorption, if you have, you can think in it if you're having watery diarrhea, excess sugar fermentation through a positive breath hydrogen test, and it does not only tell you that there is sugar fermentation, but it can tell you even which sugar, if you are trying with different sugar modalities, and if they were fermented or not. Reducing substances and the pH of the stool are frequently used in this context, and I should raise the attention of my colleagues of pediatricians that we need numbers. pH of the stool is usually acidic in all persons, in most of the infants, but in formula feed, it should be below 6, and in breastfed should be below 5.5 to say there is a more acidic stool that can suggest the possibility of sugar fermentation. And in reducing sugars, it should be above half gram in 100 gram stool. Gut morphology and immunohistochemical assessment is a research method. It's not usually needed to diagnose the possibility of sugar malabsorption. The easy way is to have this withdrawal rechallenge test, and it can tell you that there is sugar malabsorption. I will raise the attention of my colleagues that most of the diarrhea coming with a normal growth is either functional diarrhea between the age of 6 months and 60 months age, or it is due to excessive beverages and juices taken by the infants and children at that age, and just taking these juices off will improve diarrhea in many of the cases before putting them in the dilemma of investigations of these cases. So if you have bulky stool, you have to have this fecal alpha-1 antitrypsin. If it is high, think generalized intestinal pathology or pancreatic disease. If it is normal, think in a liver disease or liver disease. Liver assessment, ultrasound, lipogram, and affected systems, neurologic affection, kidney involvement in some cases, you can find. And if you are thinking with high fecal alpha antitrypsin, get pancreatic enzymes, get sweat chloride and DNA studies, test for small bowel bacterial overgrowth by lactulose with hydrogen test, get serology for celiac disease, and you may need to have an intestinal biopsy. Treatment of chronic diarrhea. Thinking in the causes? Okay, it may be of help. According to the cause, parasitic infestations can need treatment, and I raise the attention in fish-eating countries that Capillaria philippensis is getting common in these days. I'm not sure why. And we reported the youngest case of Capillaria philippensis at the age of 2.5 years. Celiac disease, it's okay. Take gluten off. This is a specific treatment. Small bowel bacterial overgrowth may need help. Inflammatory bowel disease. In acrodermatitis enteropathica, you can use the zinc supplement. And among the 10 cases I'm seeing from acrodermatitis enteropathica, oral zinc solution is very successful to ameliorate the condition. One of the very disappointing areas here that some of our pediatric colleagues will test for serum zinc, and when they found the serum zinc normal, while the patient is on zinc supplement, they stop zinc, and the catastrophic skin affection and GI pathology will start. Non-specific measures. What about constipating measures in this condition? Usually they don't succeed. Probiotics may help in some of the cases, especially in small intestinal bacterial overgrowth. Nutritional management is very important because in these conditions, malnutrition may occur. Sometimes in severe forms of diarrhea with hyperperistalsis, we may need antimotility. Take care. We don't use them in the acute gastroenteritis. Digestant juices or digestant mixtures may be used in some cases of pancreatic replacement therapy. Cholestyramine, if you are thinking in excess, toxic bile salts will be of great help in these conditions, even if you don't reach the definitive diagnosis. If you used it and it succeeded, it means that you are having a problem with the bile salts. So if you are having chronic diarrhea again, ask about the onset. If it is neonatal, is it diarrhea actually or gastrocolic reflex? And if it is actually diarrhea starting in the neonatal period, think seriously. These cases need to be definitely diagnosed. And in most of these cases, you'll find sep death, and the average sep death in Egypt I have seen is average of 3 before reaching the diagnosis of an underlying genetically determined disorder of the neonatal diarrhea. And if it is post-neonatal, think infection and infestation, think celiac or allergy, think sugar intolerance, think IBS, and if it is associated with other manifestations, you can think in inflammatory bowel disease. And by the end of my talk, I can sum up in the following statements. First of all, ask yourself, is this diarrhea acute, persistent, or chronic? Or sometimes it is recurrent acute diarrhea. Refer with recurrence more than usual. If it is recurring within 3 attacks per year, you don't need to refer, but if it is more or 4 or more, you need to refer. Allergy may present like recurrent acute infection. Failure to thrive is of bad omen in this context. So if the growth curve of your patient is not adequately achieved, please refer for both gastroenterologist and dietitian or clinical nutritionist. Antibiotic abuse should be prohibited, and it should be by prescription, not on shelf drug. And this will decrease the persistence of diarrhea. Parasitic infestations, cow's milk allergy, celiac disease are among the most common causes of chronic diarrhea. And thank you.
Thank you, Professor Mustafa, for your excellent deliberation. I think you made this very complex topic very, very simple. And that I think one of the very important message, if we have to combine both the talks, is that the growth charts. I think it does offers a lot of clinical information, and it speaks a lot about any underlying disease. I think as a pediatricians, that should be one of the the message I think we all should be driving, that there should be a minimum standard of practice that measure and plot every child when you see them. Again, thank you, Dr. Mustafa, for that excellent deliberation. So please, again, a gentle reminder about Q&As. Please ask your questions. Find yourself be in a lucky position to win one of those raffle draws today. Please don't forget to complete the survey forms. It will really help us to improvise our WIPES webinars. And before we go on to the Q&A session, we would like to have a small video presentation from the sponsors, and after which we will take up the Q&As. Please stay tuned.
HexBio is a microbial cell preparation containing probiotics, a multiple strain MCP that benefits the host by improving intestinal balance, prebiotics as fructooligosaccharide. HexBio bacterial strains include Lactobacillus acidophilus, Lactobacillus casei, Lactobacillus lactis, Bifidobacterium bifidum, Bifidobacterium longum, and Bifidobacterium infantis. Why HexBio? It is a combination of 6 bacterial strains with concentration of 30 billion CFU. Maintains and restores GI well-being. It improves digestion, overcomes irritable bowel syndrome, reduces the risk of antibiotic-associated diarrhea, improves gut function and caloric tolerance while enteral feeding in ICU patients. It is safe for infant, kids, and adults with palatable taste. HexBio can be administered orally by pouring 1 sachet directly into the mouth, followed by drinking a glass of water. Alternatively, 1 sachet can be mixed together with water or juice to be consumed orally.
We had a great number of interest that has been drawn to this program today, and we will take the questions one by one. We have questions from various people from across the GCC. So if I may run through the questions while the other viewers start their questions. So I will start with some of the questions which I have got in my chat box. This is a question from Dr. Mohammed from Saudi Arabia. This is a question to you, Dr. Taufiq. He is asking when to expect children to start improving after starting gluten-free diet, and why some children continue to have symptoms like severe diarrhea.
Yeah, thank you for the question. Actually, it depends on what type. We are talking about typical or atypical celiac disease. For those who have just mild anemia, they will start to improve within days. But those who have diarrhea, they are the most severe because they have significant villus atrophy. So for the regeneration of their villi, it will take some time. So it will take weeks to months. And some of them even will not respond. Some of them, they will not respond. This is what we call 5% of the patient will not respond. 95 will respond to treatment, but 5, they don't respond to treatment, and we have to look for other causes or to look at our management, or they, what we call them, they are non-responders. So yes, we have to wait few days up to few weeks. But those who have severe diarrhea, sometimes they might go into parenteral nutrition until they start to regenerate their villi. So also, we have to understand that when we have villi atrophy, some of them will not just improve when we stop the gluten. At the top of the villi, we don't have the lactase. They start to have lactose intolerance. So we have to be careful what we are feeding them. Are we giving them the milk, especially in young children? They have lactose intolerance. Some of them, they might have also other types of allergy, like egg allergy. So it's really complex. But in general, as a rule, we have to wait for a few weeks to a few months before we look at the improvement by measuring the TTG or clinically by anemia improving. But those with usually with diarrhea, they will take some time more than the others. And even some of them, they might go into what we call celiac crisis. They start to have hypoproteinemia, edema, malabsorption. So it's a very tricky patients. We will take them case by case.
Thank you, Dr. Tawfiq. I think that was very well answered. And just to add on to your thought process, one of the things is, children don't adhere to the gluten-free diet. They sneak, and then, parents don't know, parents don't want to say. I think when they're not responding, that is something to think for. And of course, we all have to think about outside the box about, is this really a celiac when things don't respond? Exactly. I think, thank you for that.
Exactly.
Okay, again, next question for you from Dr. Adil, UAE, Dr. Tawfiq. The reason we are all here in this webinar is because of this COVID. And the doctor here wants to ask about COVID. Are celiac patients at high risk of COVID-19? And do you recommend any special measures?
Actually, I'm not the expert in COVID, but despite the fact that we all became expert, but actually celiac disease, in general, they are not immunocompromised, despite we know that some of them, they might have asplenia, and they are more predisposed to certain bacterial infection like polysaccharides, like the pneumococcal. That's why we give them the vaccine. They are more predisposed to influenza. We give them the influenza vaccine. So celiac disease, if they are well controlled, they don't have the severe anemia, they don't have the deficiency, they are not at higher risk. But those who have the symptoms, they might get more, they are more prone to get the symptoms. Anything to do, stick to gluten-free diet, get your pneumococcal vaccine, get influenza, stay home, stay safe.
Absolutely. I think that was very well answered. I think don't forget your immunizations. Don't forget to be on a gluten-free diet. I think that's the right message. Thank you for that. So we have Dr. Ali from Oman. This is a question to Dr. Mustafa. Dr. Mustafa, Dr. Ali wants to know why we have persistent diarrhea and malabsorption after some acute diarrheas. And he wants to know if it is due to any like a specific viruses which causes this malabsorptive state. And the extension to that question, you want to ask any role of lactose-free diet that help in this kind of a situation. Sorry for that long question, please.
Okay, this is very important question, and in fact, there is no specific infectious agents that predispose more to persistence, and the same percentage of the causative agents in persistent diarrhea were the same like in acute one, but the confounding factors as risk factors are more important. For example, the use of antibiotics in an acute attack, the malnutritional state that is preceding the acute gastroenteritis attack. Actually, these are the most important two items predisposing to persistence of diarrhea. So my recommendation was to avoid using unnecessary antibiotics in acute gastroenteritis and to get sure that infants before gastroenteritis and after gastroenteritis are well nourished, because this will help to protect against further infection or persistence of the infection. And actually, in the case of lactose, low lactose or no lactose therapy in these conditions, usually we don't need it in acute gastroenteritis, but if persistent diarrhea occur, we may resort to a low lactose. And my PhD thesis, 1989, very old, was about the state of lactose in persistent diarrhea. This was my PhD thesis. And we found that low lactose is second to breastfeeding, and absence of lactose comes last. And the better is breastfeeding. If it's not available, you can use a low lactose, but not free lactose.
I think, thank you. I think the message was very clear. Whenever possible, breastfeed, and there is no second alternative. And as all clinicians, we should always be supporting the breastfeeding. Thank you for that. And we have another question to you, Dr. Mustafa, from Dr. Abdul Aziz from Egypt. He wants to ask, is there any role of cholestyramine or Imodium in persistent diarrhea? And he also wants to know, can this be used in infectious diarrhea?
Imodium is a motility suppressor, and in case with persistent diarrhea, it is an osmotic diarrhea, predominantly with some secretory component. Peristalsis is not affected in this condition, and the risk of use of inhibitor of motility will lead to a great issue of ileus and small bowel bacterial overgrowth later on, and this is not only, I will not say not recommended, but I should say it should be prohibited in these conditions. This is about Imodium. And what about cholestyramine? Cholestyramine is a bile salt attaching compound, and whenever there is a small bowel bacterial overgrowth or there is a terminal ileum issue that will not help reabsorption in an anterior hepatic circulation of bile salts, will lead to excess accumulation of bile salts. And with bacteria present, these bile salts are turned into toxic bile salts. And toxic bile salts are a major injury to the tip of the villi. So my recommendation is to use it if there is a possibility of small bowel bacterial overgrowth. And we can diagnose small bowel bacterial overgrowth by lactulose breath hydrogen testing without a need to have an endoscopy, or if there is a pathology in which the terminal ileum was taken off, like in surgeries or something like that. Not in all cases with chronic diarrhea.
Thank you. I think that was very clear. I think there is some role, but we should routinely avoid using Imodium for any acute infectious diarrheas because the child is purging, let it purge to clear the virus. I think that message is very clear for the pediatricians. I think we have got a very excellent response for the talks. You know, we are flooded with questions. I hope we can continue and take some of more questions. And again, I would encourage our viewers to keep asking questions. So very good going. You know, we are also curious to see the raffle draw as well. I think it is really phenomenal. Excellent speakers today. Okay, so next question here to Dr. Taufik from Dr. Thomas from UAE. Dr. Taufik, so patient with celiac disease and type 1 diabetes, does glycemic control improve for these patients after gluten-free diet?
Yeah, so usually we know up to maybe 3, 4, 6%, whether it is a child or an adult who have diabetes might develop celiac. Now, what is celiac? Celiac, it means a state of malabsorption. It means the villi are blunted, we don't absorb, and this surprisingly will improve the glycemic control because we don't take enough sugar. And they found that when you start treating them, when they start to improve, they put them on gluten-free diet, they start to improve, the absorption improves, and these children will need more insulin. So this is we have always to keep it in mind. People understand it the other way. They think when you treat gluten, well, when you treat celiac and the intestine recovers, patients are compliant to their gluten diet, their diabetes control improve. No, we have to be on gluten-free diet, but remember, when the villi and the intestine improves, the absorption will be higher, and maybe we need to go and adjust the dose of the insulin higher. I will leave these things, I think, for the endocrine people to deal with it more. I think maybe an endocrinology is asking.
Absolutely. I mean, when I agree. I mean, when the diabetes is not under control, and these are all a form of, interlinked autoimmune conditions. So one thing is not getting better. I think we need to look into with an open mind, for especially when it comes to diabetes, to see we have got thyroid problems or celiac problems and vice versa. Right. Thank you for that. And we have got another question to Dr. Mustafa. It is from Dr. Azu from Iraq. So he is asking how to differentiate microvillus inclusion disease and tufting enteropathy, and what is the prognosis between these two?
This is very important for our region, and in my practice, tufting enteropathy is more common than in microvillus inclusion disease, and my experience will show that both are severe diseases, and the differentiation between them needs the histopathology, whether by light microscopy or electron microscopy, to reach the definitive diagnosis. And in some conditions, we have specific gene testing to definitely diagnose on molecular basis. And regarding the prognosis between both, microvillus disease, inclusion disease, is of worse prognosis than the tufting enteropathy. And the tufting enteropathy is having two forms, a milder form and a severe form. And I don't have any microvillus inclusion disease living till more than 2 years, but I have tufting enteropathy patients living to now to 10 years and something. So I think microvillus inclusion disease is of worst prognosis, and the management plan is difficult. Tufting enteropathy, which is more common, especially in our locality, we see tufting enteropathy more because of consanguinity rate, and some cases of it may be of good prognosis or fair prognosis.
Okay, excellent. So I think there are a lot of questions, but we will try to answer as the rapid fire some of these questions, so that it's been a long weekend, so we will leave our viewers. So one round of quick 4 or 5 interesting questions I will pick up from the viewers. So this is to Dr. Tawfiq. Is there a role of steroids in celiac disease?
Oh, yeah. So as we mentioned, 95% they respond. 5% they are non-responders. As I mentioned, some of them, they come with celiac crisis where they have severe malabsorption syndrome. These patients, they might need a steroid at this point, even pulse steroid. But other things, remember, celiac disease is an autoimmune disease. If we label them as non-responders, if we have biopsy that confirms this is celiac disease, exactly, we exclude other causes, and the child is, or the patient, if he's an adult or whatever, is on, but usually this is in children, they are on gluten-free diet and they are not responding, the symptoms becoming worse, yes, we go for a course of steroid like prednisolone, and some of them, they go for more, let's say, immune suppressor, for more aggressive immune suppressor. As a general pediatrician, this is not my field. I've never dealt with a patient to put him on immunosuppressor. I dealt with celiac crisis where we need to put them on steroid and to follow them up until they improve, then we taper it. But for those, I think this is an area where we send for the gastroenterologist. This is beyond the let's say, expertise of general pediatrician. This is where we need really the expertise of the gastroenterologist.
Absolutely. I mean, there are some conditions called resistant celiac. So you may have to dig deep and look into it, because sometimes they may have a lesions and villus problems deep inside the second part of beyond the second part of the duodenum, in which case immunosuppression can be one of the modalities of treatment. Again, this is beyond the scope of the general pediatricians, but this is something good to keep in mind. Then I think you have answered this question. This is from Dr. Ibrahim from Qatar. Can we diagnose celiac without an intestinal biopsy?
Actually, this is very important question, because let's see first, some people, they have relatives who have celiac disease, and they decide to go on gluten-free diet, and they don't want to do biopsy, or they are on gluten-free, they don't want to go back to gluten. It's very important here to do the genetic testing. If the genetic testing is negative, then for sure unlikely that this patient they have celiac disease. However, if these patients used to have some symptoms, whatever symptoms, and they improve with the gluten, maybe, we cannot be sure. One condition we can be sure without biopsy 100% is dermatitis herpetiformis. In this case, we need to do biopsy from the skin. And if we see the IgA deposition in the dermis, here we can say, yes, it is celiac disease and no need for biopsy. The other thing, as we mentioned in the title, if the tissue transglutaminase IgA is 10 times more, usually this is true. If we confirm it with another test, and we do a confirmatory supporting test with the endomysial antibody, it comes positive, yes. Very rare to be wrong. No other disease will have cross-reactivity or false positive more than 10%. 10-folds the normal. So yes, we can do it, especially in children. What we are losing in children. In adults, we have to do it for one reason. If a patient is having the celiac disease for a long time, we have to detect what we call the MALT, mucosal associated lymphoid tissue tumors, lymphomas, and some other issues like inflammatory bowel disease. But in children, if we have the typical syndrome, we have the antibodies very high 10 times, we do another time they are high with endomysial, yes. And as I mentioned, if we have dermatitis herpetiformis confirmed by skin biopsy, yes, this is celiac disease. Maybe Dr. Hudhud can also add something and we can learn.
I agree with you completely, Dr. Tawfiq, and it is very clear answer. And actually, I follow the SBIGN guidelines for not doing a biopsy, although I am endoscopist, and many cases are doing well. And I agree with you for the steroids. This is very good answer for the questions.
Thank you.
Excellent. I think this was wonderful. I think we are running short of time. I think we will end the Q&A session. But one take-home message from Dr. Tawfiq N. What is your take-home message today? One line. What do you suggest? What is your take-home message?
If I will give the time for Dr. Hudhud to start, please.
Yes, please.
Okay. If you are having a neonatally starting diarrhea and it is actually chronic one, deal seriously with this condition. If you are having a good weight with chronic diarrhea, think lightly and do not refer easily and take sugars off from the food. You may improve and save money. Thank you.
Thank you.
So I was thinking about my answer. I will say, general pediatrician, they should have the courage to diagnose and treat celiac disease when it is typical. All what you need, and stop overwhelming the gastroenterologist with cases where we can treat. So we have to empower our hand. The second message I want to say it, if you allow me, to the celiac disease itself. It looks like a chameleon, has many faces. We can tell celiac disease, you can run, but you can never hide. We'll find you. The other things, as I mentioned, always we should never lose hope that things will improve, that new treatment will be found. As I said, winners don't quit and quitters never win. So thank you very much.
Thank you. Thank you for that wonderful, talk and answering these questions. Please don't forget that we have our next wipes on the 22nd of July. So please register yourself, ask questions, stump the experts. They have got an excellent speakers. They're here to, bridge that knowledge gap and share their expertise. So please do register. In the chat box, you will see a link to the registration for the next one. We also have a telegraph. So you will see in your link chat box for the telegraph. So now the most exciting time, ladies and gentlemen, to announce our winners today. I will need the help of the organizers as well to see if the winners are around. So the first prize goes to Dr. Imad El Shafi from UAE. Congratulations. Is Dr. Imad here?
Mabruk Ahmed. He's my friend.
She's here, she? I'm waiting to hear from the organizers. Is Dr. Imad here? Winner number one, okay. Maybe we will, if Dr. Imad is not there, we will go to the second person, Dr. Mervat Al Asan from Jordan. Are you here? Please, can you confirm? Congratulations. You are the first winners. Dr. Mervat? Okay. I'm just waiting to hear Dr. Mervat Al Hassan from Jordan. Okay. Let's move to the third person. Maybe again, if they're not there, Dr. Fauza Abu Ubaida from UAE. Dr. Fauzi Abu Ubaida from UAE. Dr. Fauzi Abu Ubaida? Is the doctor here on the show? I cannot see it in the chat box. Dr. Fauzi has confirmed. Congratulations. Well done. Congratulations. The first prize goes to Dr. Fauzi. All right. So now let's see who are the other winners for the second and the third prize. Dr. Rabia Ahmad from Lebanon. Dr. Rabia Ahmad, are you here? The second prize goes to you. Congratulations. I'm waiting to hear if Dr. Rabia Ahmad is there still. She's from Lebanon. Not yet. Okay. I have not received yet. Okay, let's move to the next person then. Dr. Naugi Chouana from Choha from Egypt. Dr. Naugi Choa from Egypt. For the second prize. Can they confirm? Oh, Dr. Rabia Ahmad has confirmed. Okay, fine. Thank you. Congratulations. You are the second winner. Okay, then I will announce this third prize to Dr. Naugi Choa from Egypt. Any response? Let's wait for 5 seconds to see if we have got any response. No. Dr. Naugi has also confirmed. Well done. Congratulations. So we have got all the 3 winners today.
Congratulations, Dr. Nagy.
Yeah, I wish the best of luck for the other, the selected members. Unfortunately, they could not make it to the winning list today. I'm sure you can make it in your next wipe session, which will be on the 22nd of July. So, ladies and gentlemen, and on behalf of the Wipes family and behalf of the XBio, who has been the sponsors today, thank you so much. It's been a wonderful, interaction and deliberation from the two eminent speakers. I wish you all a very happy evening and good evening. Thank you so much.
Thank you.
Thank you. And please, can I request to complete your surveys? Please, it will really help us to tailor make the requirements of the knowledge deficiency in the region. Please do write in your survey, recommend what are the things that could be changed, what you want us to consider. So it will really help us. And thank you so much. I would be really grateful if you could complete this survey. Thanks a lot. Bye-bye and good evening.